talked a lot recently about the reality of working maternity wards and how stretched the midwives are in antenatal and postnatal ward settings. How there is a huge variation, and the one thing that I've been asked many times is why can this be allowed to happen? To put it simply, is because there are no standards or frameworks to hold trusts and organisations to account. Trusts and organisations are doing nothing wrong, and the only recommendation is around one-to-one care in established labour settings. And this is why there's such variation around ratios, with even variation in whether you use acuity apps or not during postnatal and antenatal ward settings. So essentially, trusts can do what they want within reason when there are no standards, no frameworks, nothing in place. Currently, no professional body, no union, no regulatory body states what safe standards of staffing are or should be outside of established labour intrapartum care settings. Only the Royal College of Nursing had one a few years ago specifically for nursing, but it seems to have disappeared somewhere along the lines. And even the Ockenden report states the following: minimum safe staffing levels should be those which are agreed nationally, or where there are no agreed safe staffing levels, this should be locally agreed by the LMNS, so the Local Maternity and Neonatal Service. This must encompass the increased acuity and complexity of women, vulnerable families, mandatory training to ensure trusts comply with CNST and CQC requirements. Currently, only intrapartum care is mandated as needing one-to-one care in labour. So, if something happens in labour ward where there is not enough staff to cover one-to-one care, the trust are held accountable for not being able to meet that standard, which is why staff often get pulled from other areas. And because there's no mandate or standard or framework currently telling trusts to start counting and admitting babies as patients, nobody is collecting the number of babies currently requiring 2 hourly observations after birth to keep them safe, blood sugars on them, or infant feeding support to know the percentage of babies who actually require this additional care and need the additional care hours and the monitoring, which adds to the workloads of midwives to meet the basic safety requirements for babies. Let me talk to you about how more staffing currently happens within trusts, and it is through one of several ways, and in most cases it's a combination of all of this. This is usually instigated from senior leadership teams, but sometimes it can be others working in maternity who put forward a case for change. Sometimes it comes from CQC reports, sometimes it comes from adverse outcomes or investigations where staffing has been a factor, but for most places it's a business case which is submitted to be able to try and apply for more staff. This encompasses local data. For those units on acuity apps, this isn't mandated by the way, but it's seen as good practice and it's a good way to evidence what you need. But for my FOI request, most trusts only monitor acuity in labour. Just to explain what acuity is, this is the number of care hours needed to meet the basic safety care standards of women and people, and the number of staff and care hours actually available to meet these basic needs. As a side note, one interesting comment which kept coming up from responses from the organisations was, we move staff based on acuity of the unit, and then would say that they only monitor the labour ward acuity and nowhere else. So I'd like to urge these units to go back and ask the what ifs question to all of the other areas and how staff are moved based on what, because what if something happens in these other areas when staff are pulled? Anyway, the local report generated from these acuity apps will either be annually or 3 yearly based on the data, the number of births, number of caesarean births, complexities, but it doesn't include everything though, and there will be some due for renewal now who maybe have worked through the last 2 years where the inductions and the caesarean births have doubled with the same workforce as 3 years ago. Probably why we've seen lots more women who are saddened by the changes in maternity services. This report predicts the staffing you might need overall in your maternity service, either for the next year or the next 3 years. For those who are on the ward acuity apps though, this may suggest how many staff members you may need on a day-to-day basis to be able to cover your daily requirements of care. But the data has to be inputted regularly with high compliance for this to be accurate, which is challenging when you are in busy maternity ward settings. And in addition, the business case, there needs to be any other factors like the number of incidents where staffing was a factor, complaints data too where staffing was a factor, and underpinning any business case, there has to be several financial options and choices for the trusts and the execs to be able to choose from. I.e., if we mandate that one midwife can only care for 4 women, for example, this is how many additional midwives we will need to be able to actually enable this. Alternative option is if we mandate that one midwife can only care for 6 women having an induction of labour. This is what the cost will be in contrast versus what we do currently, which is nothing. The one that I haven't touched on, and this is where is the standard or benchmark nationally? What are other places, what are the trusts and organisations doing? How do we compare? This is the crux of the matter, to hold organisations, trust boards, senior leadership teams to account. Some trusts will happily find hundreds of thousands of pounds because it does cost a lot of money for additional staffing, with a robust business case based on your local data or local reports following adverse outcomes. However, others will not. If we take the Morecambe Bay findings, for example, which suddenly provided the magical number of one nurse can only safely provide care for a maximum of 8 patients at any one time, which has been implemented in national NICE guidelines. But the same frameworks, the same ratios have not been mandated in maternity services. From experience of writing a business case for something else in my career, it was the national paper, the national recommendation, the national standard which held the most weighting. And it is the national frameworks, which is where some trusts will sit up, pull their socks up, because they don't want to be an outlier and they don't want to have to defend this if there are any legal challenges or adverse outcomes where they do not implement or they have not implemented that safe standard that is holding all trusts to account. So to conclude, trusts are doing nothing wrong or nothing right with staffing at this moment in time outside of intrapartum care settings. They are doing what they need to do, what they have to do to get through. And actually, until those standards exist, until they are specific and measurable and achievable, and not wishy-washy, not woolly, and where there is a framework and a mandate implemented nationally, women are not going to get the same level of care hours that they require based on what's currently happening. Acuity apps are not mandated. Trusts do not have to do it outside of one-to-one care, intrapartum care. They have to review their staffing workforce models. That's all they have to do. It doesn't mandate the number of patients a midwife can safely care for at any one time, the number of maternity support workers at any one time to provide that care. And until that's done, as a actual specific and measurable and achievable target, make it specific, not open to interpretation, we're never going to get those safe standards of staffing models around the UK. And as a reminder, this can be, as a framework, from unions, it can be from professional bodies, it can be from anywhere. It doesn't just have to come from the maternity review, can I just point out. Unions can actually put together a report and a framework to say, this is the standard that all trusts should be achieving. Thanks for listening to my take on safer staffing in the UK, and I hope one day that we do have safe staffing levels within maternity services and in nursing care as well, overall, in all of healthcare settings, because women, people and their families deserve far better, as do midwives and support workers and any healthcare professional working in healthcare settings.